Okay, thank you, and welcome everybody to this month's Pathology Grand Round. Can I remind you all, if you have questions to ask, please put your questions in the Q&A box at the bottom of the screen, and we will discuss the questions after the lecture. It gives me great pleasure to introduce this morning's speaker, who is Professor Fatima Carneiro, Professor of Pathology, University of Porto, Portugal, where she's also head of the Department of Anatomic Pathology and a senior researcher at Ipatimup I3S. She was president of the European Society of Pathology 2011 to 2013 and president of the Portuguese Academy of Medicine 2018 to 21. She's the coordinator of the Portuguese network of tumour banks, council member of the International Gastric Cancer Association, member of the International Gastric Cancer Linkage Consortium, and board member of the European Academy of Cancer Sciences. Fatima was awarded by the Portuguese Foundation for Science and Technology for an outstanding curriculum and received the Order of Infante Henrique, Grade Grand Officer, a decoration given by the President of the Republic of Portugal for outstanding services to science in 2006. She's internationally renowned for her work on gastric cancer. She has authored and co-authored more than 400 peer-reviewed publications, 36 book chapters, including being a co-editor of the WHO Blue Book on Tumours of the Digestive System, both 4th edition and the 5th edition, which is where we met and had many discussions in Lyon in 2018 and 2019. Her research is directed towards the understanding of the etiopathogenesis and molecular pathology of gastric carcinoma, both sporadic and hereditary, and that is the subject of her lecture to us this morning, which is entitled Gastric Cancer Pathology, Recent Advances. Thank you very much indeed, Fatima, for coming and speaking to us this morning. Over to you for your lecture.
Thank you so much for the invitation and the kind words. It is really a huge pleasure for me to be here today. And as it has been announced, the topic of my presentation is gastric cancer pathology, recent advances. I am based in Porto, Portugal, a place where all of you are welcome. And not only at University Hospital, but also at the Faculty of Medicine and the Research Institute. I have no conflicts of interest to declare. And to begin with, let me summarize the learning objectives of this talk. The first is to recognize the major histological types of gastric cancer. The second, to discuss the basis of the molecular classifications of gastric cancer. The third, to learn the major molecular targets for therapy. And at the end, to discuss the role of artificial intelligence currently in the better understanding of gastric cancer. To begin with, I will address the classification of gastric adenocarcinoma, taking as the basis the classification of the WHO classification of tumors of the digestive system, and specifically in the chapter dedicated to gastric adenocarcinoma, for which there were several authors from Europe and also from Japan. It is the rule of the game in WHO that the participation of pathologists from all parts of the world should be guaranteed. That's where I met Professor Mark Arends, and it was a huge pleasure to work with him under his guidance as an editor of the sections in which I have been working. And if you come to the classification of gastric cancer, there are major histological types. These encompass tubular adenocarcinoma, composed by tubules, in this case widely invading the muscle layer of the gastric wall. The papillary carcinoma, that is constituted by elongated finger-like processes in which there are fibrovascular cores lined by columnar epithelial cells. The mucinous carcinoma, this one characterized by the presence of mucin pools that should cover more than 50% of the surface of the tumor. In these mucin pools, you can find the neoplastic cells floating, either isolated or in glands. Actually, this is the basis of the classification of tumors in the digestive system, and you can find similar histotypes, for instance, in colon and rectum. What is quite specific of the stomach is the existence of this type of cancer, designated as poorly cohesive carcinoma, encompassing two subtypes. One is mainly constituted by signet ring cells. Here you can see the typical features with the nucleus at the periphery and the cytoplasm filled with mucin. When these tumors are restricted to the gastric mucosa, there is this layering structure in which the signet ring cells are larger at the surface and smaller in deeper areas. And this is designated as the signet ring cell type. In other terms, poorly cohesive carcinoma signet ring cell type, which is the other subtype. In the other subtype, the neoplastic cells do not display the features of signet ring cells. On the contrary, they have scant cytoplasm. The nuclei are hyperchromatic, and sometimes the cells can display bizarre features. They tend to invade widely the gastric wall with desmoplasia. Another type of gastric cancer that is quite characteristic in the stomach is the designated mixed carcinomas. In these tumors, there is the coexistence in the same tumor, and I insist the coexistence in the same tumor of more than one component, one being poorly cohesive cancer. In this case is poorly cohesive carcinoma not otherwise specified, coexistent in this case with another component with the tubular structure. The latter with the signs of perineural invasion and venous invasion, while the poorly cohesive components tend to invade the lymphatic vessels, and when reaching the serous surface of the stomach can lead to wide invasion of the peritoneum. And because of these features, it is thought that accumulation of the aggressive features of each of the components of mixed tumors is the reason why these tumors have such a bad, worse prognosis compared to the other tumors in the stomach. And if you come to the classification of the Japanese Gastric Cancer Association, which I want to compare, there we have also tumors that correspond in WHO classification to the poorly cohesive carcinoma. In the last edition of this classification, published in 2017, you can see the publication of some pictures of signet ring cell cancer with the typical signet ring cells. Some of those can have this target appearance with the cyst in the cytoplasm of the neoplastic cells. And here it is also shown what I have shown before, which is the layering structure with the neoplastic cells larger at the surface and smaller when these tumors invade the mucosa or are restricted to the mucosa. This is quite characteristic. But we have also acknowledged in the Japanese classification the tumors that are constituted by poorly cohesive cells that tend to invade widely the gastric wall, as I've shown before, that in the Japanese classification are described as poorly carcinomas, non-solid type. Non-solid because the solid type is constituted by masses of neoplastic cells, while in this poor 2, non-solid type, the neoplastic cells are non-cohesive and they invade in a dispersed way the gastric wall. So this poor 2 will correspond in WHO classification to poorly cohesive carcinoma not otherwise specified, while the signet ring cell carcinoma in Japanese classification corresponds in WHO classification to the poorly cohesive carcinoma signet ring cell subtype. Having said this, we come down to the major histological classifications of gastric cancer, and I've already commented on WHO and some issues of the Japanese classification. I want also to highlight the Lorraine classification that was issued in 1965, still widely used, mainly in epidemiological studies, and Nakamura classification. Nakamura classification was published in 1968 and acknowledged only 2 major types of gastric cancer, the differentiated, all the others are undifferentiated. This is too simplistic, I think, currently in face of the knowledge we have about gastric cancer. Coming back to Lorentz classification, we can make some correspondence between the major types, intestinal and diffuse, with the major types of gastric cancer recognized in the Japanese classification and WHO classification. And when we come to the comparison of the WHO classification, the 5th edition published in 2019, with the Japanese classification, the last edition in 2017, you can see that there is a very good correspondence for many of the subtypes. Papular in WHO, papular in Japanese classification, tubular WHO, tubular in the Japanese classification, and you can have the poorly differentiated in WHO classification with solid structure that corresponds to the poorly solid type in the Japanese classification. You have the mucinous tumors in WHO with the same designation in Japanese classification. Where are then the differences? The differences are not so important as I explained already, because there is a very good correspondence between poorly cohesive signaturing with signaturing cell carcinoma in the Japanese classification and poorly cohesive not otherwise specified with the poorly non-solid type in the Japanese classification. There is a minor difference also in the designation more than in the concept regarding mixed cancer, as I explained, constituted by more than one component. And in the Japanese classification, it is not given this name of mixed carcinoma, but it is described the different components and is indicated the proportion of each of them. In this case, poorly non-solid type, more frequent than signaturing and more frequent than tubular too. So we can see that comparing these two classifications, they essentially recognize exactly the same entities, most of them with the same designations, others with minor differences. And in both classifications, there is also the recognition of special types as designated in Japanese classification or histological variants. Which are they? There are several different separate distinct entities that I'm not going to address all of them, but I will concentrate on those which have relevant impact in behavior of the tumors for the patients. Let's begin by this one. This is the so-called adenocarcinoma with enteroblast differentiation. It is composed by tubules. You can also see solid areas. And the neoplastic cells, they have this feature of being columnar with apical glycogen-rich clear cytoplasm. And this is reminiscent of fetal gut epithelium, the basis of the designation with enteroblastic differentiation. This is considered as a variant of hepatoid carcinoma, as also is a variant, the clear cell papular tumors in the stomach. And the hepatoid carcinoma and their variants and its variants express glypican-3, SALL4, and alpha-fetoprotein. Another entity recognized in the stomach is the invasive micropapillar adenocarcinoma. Here there are tumor clusters displaying what has been designated as the characteristic inside-out growth pattern with the luminal pole of the neoplastic cells present on the outer surface of the cluster. So you have clusters of neoplastic cells. We do not have a lumen in the middle, but the apical pole is directed to the surface of these clusters. Why are these two subtypes of gastric cancer relevant? They are not very frequent, but they bear a very poor prognosis for the patients. Another subtype of gastric cancer is designated gastric carcinoma with lymphoid stroma, and it is associated with infection by Epstein-Barr virus. These tumors are characterized by the presence of small nests or fused glands, and in which there is abundant lymphocytic infiltration. You can see between the neoplastic cells and also recognize intraepithelial lymphocytes. The feature of this type of cancer is the presence detected by in situ hybridization of EBV encoded small RNA by this technique, EPR. And as you can see here, the nuclei of the neoplastic cells are positive, but the lymphocytes are negative. What is relevant regarding this type of gastric cancer is that it is related with a very good prognosis, or a good prognosis, more correctly. And it is important to know also that currently there are other phenotypes, histological phenotypes, for tumors associated with Epstein-Barr virus infection. One of these phenotypes is tubular carcinoma with limited desmoplasia, in which you can identify glands, tubules, and you can also find lymphocytic infiltration in the stroma. And still another histological phenotype related with EBV infection, which has been designated as carcinoma with Crohn's-like lymphoid reaction. And you have the neoplastic cells recognized here. And at the periphery, you can have lymphoid infiltration with the presence of lymphoid follicles, as it happens in Crohn's disease. And we have another subtype of gastric cancer, which is quite rare. And to be completely honest, and I'm sure Professor Mark Arends remembers, there was a strong discussion about recognizing and acknowledging this entity in WHO book that was supported very much by the Japanese authors. Most of the cases published in the literature are originating in Japan. And this tumor is designated as gastric adenocarcinoma of fundic gland type. It is believed that is originated in oxyntic gland adenoma of the stomach, is composed by fundic or oxyntic glands, which have immature features. And at the deeper part of the mucosa, these neoplastic glands, they are angulated and anastomosing. The behavior of these tumors is very good, even when there is invasion, which usually is not in depth. But in this case, we can see the invasion of the superficial part of the submucosa. Here you can see the muscularis mucosa and the neoplastic glands infiltrating the muscularis mucosa with these atypical features of the glands. In this case, it is composed mainly by principal cells, but in some cases you can have a mixture of principal and chief cells of the stomach. As I mentioned already, the prognosis of this type of gastric cancer is very good. So I can summarize saying that when you compare the Japanese classification of gastric cancer in its last edition with the WHO classification, I come to the conclusion that these classifications of gastric cancer are very similar. Is this relevant? I think this is very relevant because there was always this discussion that is very difficult to compare results from different parts of the world because of the use of classifications that are no longer comparable. But if the authors are using these classifications, they are clearly comparable. And this is a major achievement for the better understanding of the epidemiology of gastric cancer all over the world. So having reached this stage, what about the tumor biology? And we are moving now to molecular features of gastric cancer. The first thing I want to show you is this entity. I wonder if you have seen this type of gastric cancer. Is quite rare and is designated as the crawling-like adenocarcinoma, also called as intestinal type adenocarcinoma with anastomosing glands. Actually, some of these glands, they are localized in the structure of the tumor parallel to the surface. And that's why it gives the designation of crawling-like. And there is fusion of glands. And this can be clearly seen in this inset, in which these glands are fused, giving rise to peculiar features and morphologies, reminding Japanese authors of letters, in this case as an X. And you can see other bizarre shapes such Y and other types of letters. And this has been highlighted in the Japanese literature. What is relevant with this type of gastric cancer is that you can have many goblet cells reminding you of intestinal metaplasia. And now and then, the challenge can be the differential diagnosis between this subtype that is very well differentiated from really intestinal metaplasia incomplete type. Another feature of this entity is the occurrence in a percentage of cases of cancer of signet ring cell type, as I'm showing you here between the glands with the goblet cells. You can see signet ring cells, and this is an higher magnification of the tumor in another area. This is quite strange because we have a tumor with glandular structure in which the neoplastic cells, they have the features of signet ring cell cancer. And it is very interesting in this case because there are a couple of studies addressing the molecular characteristics of this entity in which it was possible to demonstrate raw A mutations and fusions encompassing Claudin 18. And these features, these molecular features, are typical of signet ring cell carcinoma and not of tubular carcinoma. And so these are found, as I said, in intestinal type of carcinoma, but also in this specific entity, even when it is mainly constituted by these anastomosing glands. So what we can conclude, and this is a genetically distinct group of tumors with raw mutations and fusions encompassing Claudin 18, which are thought to be specific to diffuse gastric cancer and appear also in this type of gastric adenocarcinoma with these peculiar features in which you find these scrolling type structures of glands together with signet ring cells. And we come to the classical classifications, molecular classifications of gastric cancer. As you know, the first classification that is relevant for the understanding is the designated TCGA classification, published in Nature in 2014, and acknowledging the presence of 4 major types of gastric cancer. One related to EBV infection, another related to the presence of microsatellite instability, another one which is designated as genomic stable, corresponding tumors with diffuse histology, and as I highlighted before, with specific molecular alterations encompassing raw A mutations and fusions with Claudin 18 gene. And it is also important, as we know, that CDH1 alteration is a marker of this type of gastric cancer. And finally, we have chromosomal unstable tumors, which have intestinal histology mainly, in which p53 mutations can occur, as well as mutations encompassing receptors of tyrosine kinases. Another classification that was published in 2015 is proposed by the Asian Cancer Research Group. This was published in Nature Medicine. And according to this classification, there are also 4 major types of gastric cancer, but there is a difference. This classification does not acknowledge the group of EBV-related cancers that is hidden behind these other subtypes. And essentially, this classification recognizes microsatellite unstable tumors and the microsatellite stable tumors in this latter group, the tumors with epithelial mesenchymal transition alterations corresponding to the genomic stable with the diffuse phenotype. And the other microsatellite stable tumors with glandular structure, they are divided into subgroups with or without the p53 alterations. So here it is given some relevance to the presence of p53 mutations. And we ask, we pathologists, do we have access to high throughput technology that would allow us to classify our case in routine according to these classifications? And I don't think we have in the large majority of pathology labs. So what can we do? We have tools in our hands, and yes, we have tools in our hands. To begin with, you can use in situ hybridization for the detection of EBV. Here you have an example. We have in our hands the possibility of studying the expression of the proteins of the mismatch repair system, and to identify mismatch repair deficiency, which is equivalent to microsatellite instability, which can be searched also by molecular technology. And the two of them are negative. We can search for the alterations in the expression of ECAD ring. And if these are present, we would come to the group of genomic stable tumors. If all of these features are absent, we are left with a group of tumors with chromosomal instability. And here, yes, you can also distinguish between those with normal p53 expression, accounting for a very low percentage, and curiously with the gastric phenotype, and distinct from the tumors with aberrant p53, which accounts for about 50% of gastric cancer, and which is associated with higher lymph node metastases and corresponds, most of the cases, to lower intestinal classification, to the intestinal subtype. This has been tested in the United States and afterwards also in Asia, in Korea, and confirming the feasibility of using this approach for molecular classification of gastric cancer in routine practice. And when you look at these classifications, what we feel that is missing and is very relevant in gastric cancer is the HER2 expression, which is not really missing because it is eaten within the groups of cancer with chromosomal instability. And in gastric cancer, HER2 expression is observed in 10 to 20% of gastric cancer and the gastroesophageal junction adenocarcinomas. The location, as I said, is more frequent in the G junction when compared with distal stomach. The histology of this type with HER2 expression is mainly intestinal type, or if you prefer, tubulopapillary, when compared to mixed tumors or diffuse or poorly cohesive, as you prefer. And the molecular subtype of this cancer, as I highlighted already, is a group of chromosomal unstable tumors. And it's much more frequent within this than any other the groups. What can you do in routine? Of course, I think that all who are listening to this presentation are aware of this. This should be searched to begin with by immunohistochemistry. And there is a feature in the expression of HER2 in gastric cancer, which is the heterogeneity. And in the same tumor, you can have glands in which there is high-level expression of HER2 at the basolateral membrane of the neoplastic cells with an intensity that is scored as the highest, corresponding to 3+. In the same tumor, you can have other areas in which there is expression, but this expression is much lower, encompassing something that is only weak or moderate and can be seen in the basolateral or only in the lateral membranes of the neoplastic cells. And these features can coexist with other types, with other areas in which there is no expression of HER2. This can clearly be seen in surgical specimens, but is also a feature that we should be aware that is corresponding also in the biopsies, in the cholecystoscopic biopsies. And because these are very small, there is the minimum biopsy set in which HER2 evaluation should be made. And actually it was advised that in gastric cancer, to make sure that we have enough representation of the tumor, at least 5 to 8 samples should be collected by the endoscopist to account for the heterogeneous expression of HER2 or other markers. There are well-established guidelines for this evaluation. I gave some examples already. The guidelines encompass recommendations for the study of surgical specimens, in which the percentage of cells with the different features should be in more than 10% of neoplastic cells, while in biopsy specimens, we should search for clusters of neoplastic cells, and in these clusters to look for the pattern of expression that I already mentioned when I comment this picture. So how can this be scored, the expression of HER2? It can be completely negative in one end of the spectrum. The other end of the spectrum, the neoplastic cells exhibiting more than 20%, 10%, the features that I already described, and this is scored as 3+. In this case, there is no need of additional studies. This is considered as 3+ positive, while when it is very mild expression together with negative, this is considered as negative for further treatment of the patients, and there is no need for additional studies. We are left with the case scored as 2+, as in this area, or tumors in which only this area is present, in which in situ hybridization should be performed for the identification of amplification of the gene encoding for HER2. These two groups, when positive by in situ hybridization, are the candidates for target therapy. The other molecular pattern that we pathologists can look for is for the mismatch repair deficiency. So the immunohistochemical expression of the proteins of the mismatch repair. Here I can show you one case in which it was studied expression of MLH1, PMS2, MSH2, MSH6, the four that we search for in routine. In this case, 2 of them were lost. You can see here immunoreactivity, which is exhibited in the nuclei of lymphocytes, but not in the neoplastic glands. So this tumor is deficient by immunohistochemistry. As I mentioned already, we can search for with molecular tools, and now we are talking about microsatellite instability. We are studying the features in the genome itself. And you can also use currently, although I don't think it's widely used, NGS technology. And according to the patterns detected, we can come up with instability signatures and calculate instability burden. And there is a correlation with overall survival, but I don't think we have this introduced in our routine practice. This is very important because tumors with microsatellite instability, the patients are candidates for immunotherapy using, for instance, pembrolizumab that is well established since 2019. And these tumors correspond to tumors with microsatellite instability in TCGA classification. And there is also other phenotypes of tumors with microsatellite instability that are similar to the phenotypes that I described for the tumors with EBV infection. One is gastric carcinoma with lymphoid stroma that can be seen with EBV infection cases, also with microsatellite instability, and the other similar to EBV cancers, which is carcinoma with Crohn's-like lymphoid reaction. And here you have another example in which you have lymphoid follicles and abundant lymphocytic stroma. And in this case, there is loss of expression of these proteins in the glands, although the nuclei are positive. Is this relevant? Yes, it is, from evidence published in the literature, though more recent evidence is not so clear regarding this issue, and is relevant because of the impact on the survival of the patients or progression-free survival for patients submitted to standard chemotherapy. And if you look at the tumors with microsatellite instability in this magical trial, you can see that the patients submit to surgery only had better prognosis regarding survival than the tumors, the cases of patients in which there was the treatment not only by surgery, but also chemotherapy. It seems that chemotherapy impacts a poor prognosis in these tumors with microsatellite instability. This was observed in the series, this from US, from the Memorial. And here you can see that patients under chemotherapy, those with microsatellite instability are in red. They had the progression-free survival that was much worse than the patients without chemotherapy. And you should be aware in gastric cancer, as in the tumor models, that is not the neoplastic cells, but also the microenvironment, and namely the inflammatory and immune cells, encompassing dendritic cells, CD8 cells, B cells, neutrophils, so on and so forth. And it has been suggested this gastrointestinal immune prognostic signature, described as GIPS, And there is a relationship between the cases in which there is a high gastrointestinal immune prognostic signature, in which there is upregulation of interferon, cytotoxic activity, tumor mutational burden high, and these tumors, they have a better prognosis when the patients are submitted to immunotherapy. And you have to come to PD-L1. I'm sure everybody is aware of the role of PD-L1 in different tumor models. In the stomach should be evaluating neoplastic cells and also in immune cells in the stroma, neoplastic cells at the cell membrane, immune cells in the cytoplasm. And for the stomach, you should come up with a score that is a combined positive score in which you have to calculate the positive cells, not only tumor cells, but also lymphocytes and macrophage, and the sum of these divided by total number of viable cells. Here you have some examples, one of high expression of PD-L1 in the neoplastic epithelium, the moderate expression, here the expression in the immune cells of the stroma, and this is a positive control. And in my experience, I think this is really difficult to evaluate the expression in the stromal cells that is necessary for the CPS evaluation. And we come now to the major established biomarkers for gastric cancer in patients that have inoperable or metastatic or recurrent gastric cancer. Of course, the cases were HER2 positive or ERBB2 amplification. They are candidates for treatment with this monoclonal antibody, and the tumors with microsatellite instability or expression of PD-L1 higher than a certain percentage that is variable for tumor to tumor or for tumor type, and these are candidates to immunotherapy. As I mentioned, it was approved for solid tumors in 2019. More recently, pembrolizumab and chemo has been approved already as first line for gastric cancer, and also as first line nivolumab plus chemo in specific circumstances. The CPS approved by FDA is slightly different from those approved by EMA in Europe. And you have other biomarkers, for instance, Claudin 18.2, which is an addition molecule that is characteristic also of diffuse gastric cancer. And it was demonstrated that the use of this monoclonal antibody together with chemotherapy in cases in which the neoplastic cells express Claudin 18.2, they have a much better prognosis than the patients that have not been submitted to this treatment. There are also the genetic molecular alterations concerning fibroblastic growth factor rearrangements, MET amplification, and TRAC fusions, ATM loss, so on and so forth, that gain momentum, but you do not have time to go through all of them. If you are really interested in this topic, I strongly advise you to consult this paper published in Nature Reviews Clinical Oncology late in 2021, in which you have the established biomarker guide therapy encompassing all the examples I've been talking about, but also potential biomarker guide therapy in which the candidates are currently studied, such as fibroblastic growth factor receptor, epidermal growth factor receptor, so on and so forth, also encompassing tumors with EBV expression. And we come to the last point I want to address, which is the role of artificial intelligence, in a sense that artificial intelligence can help morphology and omics and put these two aspects together at a time, and can lead to reconstruction of information that aided by artificial intelligence. I think that is beginning to be considered for diagnosis. I'm giving to you 3 examples coming from literature, recent papers, this one from World Journal of Gastroenterology in 2021, and the authors were using deep learning approach in an attempt to predict the genetic alterations in gastric cancer using all slide images of gastric cancer. And they evaluate the feasibility of classifiers for mutations in different genes. And they demonstrated that it was possible to distinguish the cases, for instance, for ERBB2, I'm talking about the gene in which there is a predominance of mutated ERBB2 amplified, or in which there is mainly a wild type, and in case in which there is a mixture. So this study confirmed, according to the authors, that this deep learning approach can predict major mutations from HND stained slides using all slide images, as I mentioned, when the system is trained with appropriate data. This is really challenging. I think has to be demonstrated in other series, but is something that is really relevant. Another study I want to highlight, this is a retrospective multi-center cohort study. Here the aim of the authors were, using all deep learning classifiers, try to identify gastric cancer with features of Epstein-Barr virus infection and microsatellite instability. I described already that they have similar morphological features in histology, and they demonstrated that they could distinguish, for instance, in this square, what we have is a part of normal mucosa and tumor glands, and it was possible to distinguish by this technology the two distinct areas. According to the experience of these authors, this process can reduce the number of molecular tests required to enable universal screening potential, even in low-resource healthcare systems. We are still far from this phase, but we are looking at the future. And they highlight also that this would enable faster clinical decisions and offer therapeutic approaches tailored to the molecular profile of individual patients. And again, we are looking at the future, but looking forward to reach this stage. And finally, I want to show another study, and this was published already in February 22. This is coming from Germany, again, using deep learning technology and using hematoxylin L-zine stained slides. And this technology outperforming the immunohistochemistry in predicting the molecular subtypes of gastric cancer. Here you have an example, the different subtypes of gastric cancer that can be predicted by the system, and the demonstration in the specific case of different areas, in a way highlighting one feature of gastric cancer, which is its heterogeneity. Having said this, I want also to highlight one also very recent paper, also from February 22, in which, using artificial intelligence methodology, the authors were able to predict 32 gene signature for gastric cancer, more importantly for me, 4 molecular subtypes, corresponding type 1, 2, 3, 4, one to microsatellite instability, other to mesenchymal transition, and the other to chromosomal instability, and demonstrating that, for instance, for group 1 with microsatellite instability, the patients with, if treated with chemotherapy, the prognosis is worse, confirming previous results that I commented. And also for group 3, which is chromosomal instability equivalent, if the patients submit to chemotherapy in this setting, they have a better prognosis because the tumors are sensitive to chemotherapy. So the future is now, or almost now, I don't know. But what I want to highlight, I am coming to an end, and whatever we do, we should always have as the central part of our attention the clinical phenotype. We should add the pathology, molecular pathology, all these features I've been commenting, genomics, epigenomics, transcriptomics, proteogenomics, putting together currently artificial intelligence, all these for better understanding translation to clinics in the era of precision cancer medicine. So I think that bridges are being built, connecting science and patient care. And this is the Douro River in Porto, beautiful as you can see. And I think this is a vision for the future, but maybe the future is approaching faster than what we could anticipate before. And I am coming to the end on time, I think, and a big thank you for your attention.
Fatima, thank you very much indeed. If we were with a live audience, there'd be a very loud round of applause for you at this point, I'm sure. I'd like to thank you very much indeed. I thought that was an absolutely fantastic talk and brought us right up to date with all the recent advances. So thank you very much for that. Now, we do have one question that's appeared in the question and answer box, which I will start with. This is a question from Sarah Aitken, who asks, using machine learning to detect molecular changes and clinical phenotypes from digital pathology images is really exciting. What steps do you think we need to take to be able to get this into practice? Do you think it could become part of the WHO classification over time?
Thank you so much for this question. This is really relevant. And answering to the last part of your question, I would say yes. I think that in the next WHO classification, these issues should be considered and discussed and approved for routine practice, yes or no. It depends. We should be aware that WHO classification intends to provide the means for a correct histological classification that can be used all over the world. And though the technology, if confirmed by other studies, will demonstrate, I think, that artificial intelligence can be incorporated in routine, I'm afraid that for long, this will be available only in differentiated centers. So I think it will be discussed and commented and balanced according to the facilities in different settings all over the world. But I'm sure it will be discussed.
Okay, thank you for that. I'd like to ask a question next, if I may. If I could take you back to the fascinating findings you described for the crawling-like adenocarcinoma, where you described the presence of ROA mutations and also fusions between Claudin 18 and ARH gap, which you said were typical of this type of patterned diffuse infiltration. My question is really why? Do we have any understanding of the mechanism? For example, I know some of the family of Rho proteins are involved in the cytoskeleton of the cell and cell movement. Could the mutations in ROA, for example, be one way of disrupting those functions and allowing this patterned diffuse infiltration?
Again, Mark, thank you so much. I think that the interpretation you are giving is the correct one. I think is the presence of mutations ROA that are behind the alterations in the cytoskeleton and the transformation of the tumor to invasive component with the features of isolated or poorly cohesive diffuse type. This is absolutely fascinating. The number of cases reported in the literature is not a big, because it's a limited number of publications, but it's not only one, the one I've shown. There are the publications showing the presence of diffuse gastric cancer, and we must be aware of that. It was very recently that I came across, and I've already seen 2 cases in our routine. Since this was described in Japan, I wanted to be sure. One of the cases, the one I've shown that was really challenging, was brought to me as a consultation case. And the problem of the pathologist was, is this intestinal metaplasia or is this a subtype of gastric cancer? I thought it was a subtype, and there was also the coexistence of those. Even so, I submit to Professor Ryoji Kushima in Japan, who is a super expert in gastric cancer in these rare entities, and he confirmed our diagnosis in 2 cases. I'm highlighting this because we may be missing some of these special types of gastric cancer, and we should be aware it's really amazing entity. We have some questions.
Thank you. Yes. Okay, so we have another question in the Q&A box from Bharat Jasani. Bharat asks, how reproducible and reliable is the PD-L1 scoring in gastric cancer in light of the difficult histology presented in the gastric samples and biopsies?
Well, I think this is a $1 million question, and there is not yet enough evidence to say you in a very objective way how reliable it is. As I said, I find evaluation of PD-L1 in the stomach really challenging. The clinicians are requesting for everyday practice, and it is really a headache whenever you go to the microscope, because in the stomach is different from lung, because they are evaluated the neoplastic cells. In the stomach, you have to evaluate also in the stromal cells, but on immune cells, on your lymphocytes and histiocytes, and you have there the types of cells, and you have even polymorphs and fibroblasts and other types of cells, and I find it extremely difficult, time consuming, so on and so forth. Why is this not so relevant actually in practice? Is because the guidelines, the cutoffs for clinical applications are very low, generally more than 1%, more than 10% by European guidelines for certain applications of immunotherapy. So your life becomes easier because that you can be aware. If we would come to higher scores, I think the problem will be even more important, and the reproducibility is something that has to be demonstrated. Is something that someone should be aware of this. I think within PATSOC, a working group should be stimulated to take care of this, because this is a very relevant question.
Oh, yes, I agree, absolutely. Thank you. So the next question is from Heike Grabsch. She asks, how can we tackle the problem of inter and intra-tumour heterogeneity in gastric cancer? A, do we as pathologists need to be more precise in describing it histologically, as our Japanese colleagues do? And or B, do you think that this intra-tumour heterogeneity is a reflection of tumour evolution?
This is coming from Eike, and
Yes.
I want to say hello, Eike. And I wanted to highlight that Eike has been a co-author of WHO classification. So in a way, she is only expressing some of the concerns that we had during our discussions. So regarding tumor evolution, I think that some of the features in tumors that are heterogeneous represent tumor evolution. But in some types of gastric cancer, those that, for instance, have the typical features of mixed carcinomas, as we recognize in WHO, this feature can be present from very beginning of the tumor. And as I've shown with the crawling type of gastric cancer, this is an example. Actually, that is a mixed tumor, and those features are present from very early because of some specific molecular features. So I think the two answers are correct. In some cases can be present from very early, while in others are the result of the evolution of the tumor. We had big discussions in the good sense, comprehensive, with Eike and others, for instance, only in the group of poorly cohesive carcinomas. And there, the major challenge you have faced was to be aware of the different percentage of the tumor types, because it's different to be composed only by signature cells or poorly cohesive, not otherwise specified. And in the middle, you have a mixture. And it was really challenging. It was only because the scientific quality of Eike was being behind these studies that we still are interested in this. But it's very challenging. It's not as reproducible as you would like. And I think we should go on. But Eike is also addressing the other issue regarding the mixed tumors or tumors heterogeneous. And the Japanese authors for these, they are very detailed in the description. So they describe the different components and they indicate which is the most predominant in comparison with the last and those in between, giving the picture of what the morphology is. That is very correct from the pathological standpoint. I'm not so sure that implications in everyday practice would be as big as those, namely regarding therapy, and these days in which therapy is based in molecular features, and more will be based on that. So this will overcome, in a way, this heterogeneity for which the agreement between observers is also very difficult to reach.
Thank you. That's a very comprehensive answer. Thank you for that. So we have one more question in the box, which is from Marnix Jensen. Marnix says, "Thanks, Fatima. Do you routinely request HER2, mismatch repair, PDL1, and EBER on all biopsy and resection specimens? I know this varies significantly between sites." And he adds, "PS, I have never diagnosed enteroblastic GC."
But Marnix, thank you so much. You should pay attention because they exist. We have a couple of cases. And when you consider the possibility, you should always come for the markers. I've been commenting glypican 3, SAL4, alpha-fetoprotein, but they do exist. Believe me, you know they exist. And regarding the first part of the question, because of the clinical requests for the application in therapy by routine, yes, we search for HER2, mismatch repair proteins, and PDL1, not always EBER.
Okay, well, thank you very much indeed for that. It's very nearly 10 a.m. and we do have a tradition on the pathology grand rounds that we like to finish on time so that people can get back to work and get on with the rest of their day. So I'd like to finish this morning's session by thanking you again, Fatima, for a really excellent talk, superb talk, very well described, superbly explained, very impressive indeed. So thank you very much.
Thank you so much, Mark. Thank you to everybody and for the questions also. Thank you. It was a pleasure.
Thank you. And that's it for today's session. Thank you.
Bye-bye.
Goodbye.